Hello, everyone. Hope you had a good break. We'll start now our final section of the course, which will be about transplant and the future. So it's a real pleasure to start with Dr. Roslyn Mannon from the University of Nebraska. And Dr. Mannon is a professor of internal medicine and pathology microbiology and immunology at the University of Nebraska Medical Center, where she's the vice chair for research for the Department of Internal Medicine and associate chief of research in the Division of Nephrology. A Duke-trained nephrologist, Dr. Mannon is a translational investigator focused on late kidney allograft outcomes. She has published over 250 peer-reviewed publications on chronic allograft failure and post-transplant complications in therapeutics. Dr. Mannon is a past president of the American Society of Transplantation, and is a deputy editor of the American Journal of Transplantation, the premier journal of transplantation. She's a trustee of the Banff Foundation for Allograft Pathology, chair of the American Society of Nephrology Transplant Policy Committee, and member of the SRTR. She's a recent recipient of the AST's Senior Achievement Award in Clinical Transplantation, as well as the AAKP's Medal of Excellence. As a junior investigator in transplant, I can say she's also all of our role models. It's a real pleasure to have her here today. Thanks very much, Dr. Mannon.
Well, you'll be excited about whether I am the right person for this, if I can get the technical aspects working. So I did test this, and I apologize if I'm running late. Well, thank all of you for inviting me to speak. I'll say it's been a tough morning as a nephrologist, and I apologize for being late. But spoiler alert, I believe the answer is yes to this question. These are my disclosures. Again, some of this is my opinion. Some of this has really been developed through my years with public policy with the ASN, and really appreciate their contributions, as well as work I do with as a medical director, and the other biopharmers are not involved here. So I wanted to start off by describing and showing the Human-Centered Design Subcommittee of the Scientific Registry's depiction of a patient's journey through transplantation, and highlighting that it's really this turquoise line that we should be focused on. But many of you may not necessarily live in a city that has a subway or travel to a country that does, to recognize all of these different stopping points. But we thought it was important to have a depiction that individuals could study both as patients, caregivers, and to also show the multitude of what's involved in transplantation, specifically kidney, including living donation, the referring physician, the center itself, regulators and payers that play a key role in how we operate, the organ procurement organization and donor hospitals, as well as recognition of donor families, and living donation shown here in yellow, with our with our goal really of creating long-term survival for a patient. But this complexity of this system, which developed really initially out of hospitals trying to perform life-saving transplantation, leads to some of the issues that we need and require for policy and quality improvement. I just want to remind everybody that kidney transplants are the most frequently transplanted organ, both in the US and internationally. Shown here is data from the annual data report of the SRTR this past year, highlighting the rather abundant number of individuals on the kidney waiting list. This is overall waitlist candidates, almost 150,000, probably more like 100,000 active. And then in the corresponding period of time, we've increased our transplant volume. We're still currently only transplanting about 30 to 35% of our waiting list. And we have had improvements. The system is working hard. In the last 25 years, we've more than doubled the number of kidney transplants. Again, pointing out that the vast majority are due to deceased donor, not the big jump in living donor that's contributing to this. And we now have over 250,000 individuals that have kidney transplants. Now, when you compare that to patients with hypertension or people living with HIV or cancer, this seems like a small number, but to those of us in the field, this is really a quite large and dramatic number of individuals that we hope to continue to increase. And part of the reason that we have so many more transplants, I think, is that the use of the modality of kidney transplantation not only shows an improvement in patient quality of life, but there are significant data or abundant data to show that whether you're female or male, and regardless of your age, that there is a significant and measurable survival advantage to receiving a kidney transplant. And many of our patients now are over the age of 50 and conceive even doubling their lifespan by receiving a kidney transplant. But there are a number of challenges in addition to the complexity of the system. And I want to point out that stagnating rates of living donation exist. And I'll talk more about this in depth when we talk about advocacy for living donation. Many of you may not be aware of this, but a larger proportion of deceased donor organs is coming from donation after cardiac death determination, or DCD. These organs are really critical for our organ transplant system. In 2023, they accounted for about 26% of donation. That number is up to over 40%, some centers a little bit higher. And I just point out that there is an association of DCD donor kidneys with delayed graft function, which is acute tubular necrosis and AKI after transplantation. This is important to note because it complicates post-transplant management. It affects post-transplant immunosuppression, dialysis care, and also long-term graft survival is reduced in these. But they do provide patients opportunity for getting off dialysis and being transplanted with those caveats and recognizing that their care is more complex. And then another real big challenge in the field right now is the non-use of recovered deceased donor kidneys. This is information from the annual data report. This is the right kidney, showing that of 15,000 donors, 4,300 right kidneys were not used back in 2023. If you look at the left kidney, it's very similar. And this non-use issue continues to be a challenge to the field that I'm not sure I will completely be able to address just with policy changes, but let's see. So where did we come from? So I'm old enough to remember that there was this organization, but not that old, called CEOF, which was like the Southeast Organ Procurement Foundation. And I know about this because I trained in the Southeast, and I remember physicians and surgeons in transplant being part of it, but it was a group initially of professionals, but later, and HLA labs, but later really with a goal of trying to allocate organs and use better matching. But it was sort of like an ad hoc group. And finally, in the early 80s, it merged and it started like, I think its first allocation sequence in 77, but it was regional, and then merged with the United Network of Organ Sharing in the 80s. And it was in 84 that the National Organ Transplant Act was passed by both houses. This established the Organ Procurement Transplant Network to maintain a national registry. And the idea was that this network would not be run by the government, but would be run by a private not-for-profit organization under a federal contract. And that contractee has been United Network of Organ Sharing really since the inception of the OPTN. There haven't been really any changes until 2000, and you'll hear people talk about the final rule, the OPTN final rule. But again, there was new laws established to change the regulatory framework for the operations of this organ procurement transplant network. And I put a hot look in the slides in case you like reading regulatory language. I have a love-hate relationship with it. But it mentioned a few things that I wanted to point out to this audience, some of which are more nuanced. But one is that it included an advisory committee on organ transplantation to the Secretary of HHS. Now, this committee, which I was familiar with a bit when I was president of AST, has been relatively inert. But the goal was that the complexities of transplant required specific advice from transplant professionals directly to the secretary. It also had the OPTN contracted to UNOS for policy criteria, performance evaluation, and it requires that transplant centers have to be in good standing and that they are reviewed by a committee called the Membership and now Professional Standards Committee, or MPSC as we know it. And it also required a scientific registry to be operational pursuant to this particular act. Specifically, we now call this the Scientific Registry of Transplant Recipients. The contractor is SRTR through Hennepin Health Research Institute since 2010. ASN has really been critical in guiding principles and guiding policy, and a lot of the credit goes to our past president, Michelle Josephson, who is a transplant nephrologist. And the notions really are 5 key principles. One is to maximize access to transplantation, as we recognize it as an optimal therapy for kidney failure, both for quality of life and survival. to acknowledge that many simultaneous changes to the current ecosystem have to occur in order to achieve this goal of maximizing transplant. And we are right in the midst of that. To require that every component of the kidney health ecosystem works synergistically towards the goal of maximizing patient access. That we need to focus on eliminating patient barriers, and these include geography, race, ethnicity, socioeconomic status, and yes, sex and gender. And again, I've had an opportunity to have practices in different parts of the country. And though I grew up in a metropolitan area, I now recognize that the rural nature of healthcare is a real challenge, particularly in transplantation. And finally, to embrace the opportunity to increase survival. And so the society recognizes whether it's increasing deceased donation, living donation, and even as we move on to xenotransplantation, this is an important consideration. And so when we're thinking about our strategic aims in policy, specifically towards transplantation, we have these 5 principles to abide by. Now, it's not failed onto some of you that the federal government has been very interested in transplantation, and there's been many outspoken individuals, and to the point that the National Academy of Sciences actually convened a multidisciplinary group in 2022 to outline recommendations for our transplant system, highlighting the need to address the inequitable access to transplant, to provide more information on the pre-transplant phase, which is somewhat difficult and disconnected because it involves perhaps dialysis units or physicians working with chronic kidney disease patients and not the transplant center itself. And then providing transparency, be it public dashboards of standardized metrics, and human-centered design pictures of the transplant experience. And one example of that was part of the tasks of the SRTR, as I showed you in the first figure. And many of you may be aware or not aware, but I just wanted to note that there were 2 U.S. Senate Committee on Finance hearings, one in 2022, one in 2023, and then a House Energy and Commerce hearing in September 2024. The themes of each of these hearings were mainly identifying concerns in the transplant system, the first meeting primarily calling out UNOS and its functions or lack of function. The second, I can't remember, but a lot of drama. And the third, really talking about donation after cardiac death and accessibility of donation and donor families. So needless to say, with all of this government focus and much energy, in July of 2023, with support by the ASN, we advanced transplant infrastructure, and the Securing the U.S. OPTN Act was passed by both houses. I hate the name because the short name is SUS-OPTN. It makes it sound like there's some nefarious things going on in the OPTN, and certainly the transplant field has had its fair share of negative publicity. But this modernization initiative was to support accountability and transparency. And again, let us remember that our volumes have doubled or more than doubled, and plus other solid organs that have been incorporated in the transplant system since the final rule was passed. And developing capacity in the system was really one of the key goals. The notion was to be modernized, to have appropriate programmatic support, to allow really an expansion of resources from what we currently have, to make data available. And this is particularly crucial now as AI continues to move forward to assist in making decision making, but also improving data transparency, and having multiple data sets that actually agree would be really nice, because much of how we build policy is based on data. Engaging stakeholders, as I showed you, there are many stops on the transplant journey, and we have many individual stakeholders that need to participate and help us prioritize those needs. And then improving the OPTN functionality, which includes changes in the board governance. The notion here was really that this would diversify the field of potential contractors, really improve functionality by increasing competition and increasing innovation. So is there change going on? Most certainly. This is probably one of the most controversial areas right now in transplantation. But things that aren't controversial are that this act really helped allow us to work with appropriations and federal offices to remove funding caps to HRSA, and HRSA houses the Division of Transplantation. And our government affairs team and many of our members have been advocating consistently and positively for getting more funding. Competing multiple contracts. There are now separate boards for the OPTN and the actual operational issues of the OPTN. And there are ongoing board elections, so we can talk about that in the Q&A if we'd like. But again, this is a whole new broad set of individuals dedicated to transplantation in their careers, but without prior connection to UNOS. I guess the notion really being that there was no bias implicit, and these are all experienced individuals. And key tech areas that I would focus on are, improving our technology, for goodness sakes, because the system of UNET has been around for a very long time, data transparency and the ability to improve. And I will say that some of what's going on now is also because there is going to be a change in the administration in HHS. As many of you know, this restructuring is going on, and whether HRSA will exist or not, or where we'll be located in transplant, is not entirely clear. I don't bring this up to be scary or a harbinger of bad news. It may be good news. It's just something that I think about at night when I'm figuring out how the transplant system is going to evolve. Part of where we are standing now is related to the first Trump administration. And shockingly, this was a really key initiative in an executive order that was signed, the Advancing American Kidney Health Initiative. Many of you were there in DC, and many patients as well. And I want to point out two areas that were really consequential to transplant. The first was that there was a considerable focus on improving access to transplantation. I think this is related to the Health and Human Services Secretary at the time, who had a father who had kidney disease and wanted to recognize transplant as a key activity. And another focus was enhancing care delivery models through the Centers for Medicare Innovation. There were two models that were developed, the ETC model, which many of you know was more focused on home care and is ending soon. And then the KCC model, which was supposed to end in 2026, but I received an update within our own government affairs that, the model provided a significant financial bonus when transplants were performed. And we're aware that I think about 30 or 35% increase in kidney transplants in this program, so much so that expenditures really exceeded what they anticipated. And so the transplant bonus will end in January 2026. However, there is another opportunity to enhance transplant through another model. And that is the CMMI model known as IOTA, Increasing Organ Transplant Access. I must say that as someone who appreciates these shortened versions and ways you can chit chat and impress your friends, picking the smallest letter in the Greek alphabet was not what I would have picked. This model was proposed publicly in 2024 and finalized this past November. It is a 6-year mandatory model that will begin in July. And it involves half the transplant centers in the country. And really the aim here is to increase access to transplantation and improve access to and improve our outcomes, but also importantly to reduce healthcare expenditures through 6 goals. And the goals improve quality of care before and after transplant. Maximizing the use of deceased donors, as I indicated, is an important problem. The improvement in live donation and assisting living donors through the process, greater access to transplants for those that have issues in terms of where socioeconomic barriers and social determinant barriers to transplant, improving care coordination and patient-centered care in kidney transplant, and importantly, like I say, we like to save money. So shown here is a map of those centers that are involved in the dark blue. These centers are all constructed around donor service areas, which are the way the organ procurement organizations used to function. However, they give really sort of a broad swath of both rural kind of healthcare and metropolitan healthcare shown here, and then healthcare in the Deep South as well, where many of our patients are on Medicare. This program really only applies to the Medicare insured, whether they're primary and secondary. So about 2/3 of patients would be part of this plan in those centers. The plan is constructed about incentives. The incentive is an achievement incentive, which is the largest part of the plan, which is increasing the number of transplants relative to a rolling target. efficiency, which is a metric within transplant programs where they can look at how many organs they were offered and how many they accepted. And this ratio will be put on a median scale across all hospitals with a goal that if you're above the median, meaning you're accepting more organs relative to others, according to what you're considered acceptable, you would get more points. And then a quality initiative, which is composite graft survival, that is unadjusted. And just as an example, if you're at a program that's participating and you do about 200 transplants per year on average, just increasing your volume by 5%, say 10 transplants, can lead, depending on how you do with efficiency and quality, anywhere between $500,000 to $1.7 million to the transplant hospital/center to add into additional resources. So one question asked frequently is this really feasible? Can we push the system? If everybody's going to keep moving forward, can we do that? And so I used this tool from the scientific registry. It's called the Explorer tool. And I identified that, within the past 5 years, we've increased the growth in deceased transplantation by about 20%. Although live donation, not shown here, has fallen by about 8%. And again, that's reflective of COVID. And the growth of kidneys recovered has been absolutely dramatic from 2019, from about almost 20,000 to well over 31,000. But I would also say that our growth in non-use kidneys has really increased dramatically as well. And so, figuring out how to manage this issue, is it donor quality? Is it cold ischemic time? Is it preference? Is it offer filters? All these terms that transplant centers use, this really needs to be addressed. This model had some issues, and I want to say very proudly that we spent a lot of our summers working on giving feedback, and a number of you on this that are presenting today really provide very valuable feedback. We were able to increase the upside payment of the model in order to make it sound and worthwhile. So this 15,000 number seems to be the number that they used in the KCC model. We minimize the downside because we don't want to penalize centers that are doing transplant. We just want to maximize and incentivize them. And there were targets that were included that really didn't make sense, that some were mathematically impossible, as I outlined here. Some of the quality metrics were really out of the hands of the transplant center, like colorectal cancer screening post and some other issues, but there is a voluntary opportunity for health equity. So I just want to address in the last few minutes a couple of the other issues we're addressing. As I indicated, living donation rates have stagnated. They went up in the early 2000s when the Health and Human Services Secretary was dedicated to transplantation and donation. As a governor in Wisconsin, he led big efforts with the university there. There were significant improvements here in terms of live donation as well as deceased donation, but it kind of petered out, and then it rose right before COVID. And then we saw this dramatic drop during COVID because we did not want to bring healthy people into the hospital, and also we didn't have capacity, and we've been slowly increasing. But there are real barriers to live donation, and it's not just psychology or the fact that we're very difficult in picking medically suitable individuals. I think one of our big problems is financial neutrality. So the ASN has been supporting the Living Donation Protection Act. Lord knows that has been evolved for the last 15 years. I think the main focus now is really in removing insurance barriers to living donors, so that they can remain insurable for their lifespan. Again, it has new sponsors, and it has been really trimmed down to really focus on a couple of issues. The HOLD Act has been something that our ASN has strongly supported, again, adjusting the eligibility to provide financial support to the donor recipient, to the donor, and it's based on donor income, not recipient income. When this National Living Donor Assistance Program was set up, I think it was really set up in the notion that family members were giving to each other and that families share income. I don't know, not my family, but again, it's outdated, and many of our living donors now don't know the recipient or are part of, paired donation, for example. And so this should not be linked to the recipient. And also importantly, to grow and stabilize the funding for the program. There are other concepts out there, including the End Kidney Death Act. ASN doesn't outrightly support this. I mean, this is a refundable tax credit, and there are some ethical issues in terms of payments. But I certainly would like to say that while I don't personally support it, I don't stand in the way of having it discussed, and maybe we can actually change the language in the bill if the bill ever goes forward. Finally, organ procurement organizations. There are changes by CMS under the way that are due in 2026. It's coming up. There are 3 tiers of OPOs: high performing, medium performing, and low performing. This lowest tier, and these are all regulated based on expected donor ability, authorization and acquisition of organs. The lowest tier will lose their contracts, apparently, and how that will happen and what transplant disruption will occur has yet to be defined. But for example, the lowest tier in 2022 covered over 141 million people. And so this is a very large population that is served by that organ procurement organization. And ASN has reached out both to CMS to request that they share these plans for continued patient access. Innovation is important. We've been a strong supporter of Kidney X, and I just highlight some of this as just direct congressional funding. And finally, patient-centered metrics. This is from the Task 5 meeting a couple of years ago that was held by the SRTR. And again, many of these recommendations are along the lines of our philosophy: data, 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 and data transparency, which I think are important. Finally, I'd be remiss to say that we have challenges right now. We have workforce challenges in nephrology in general and transplant specifically. ASN has worked with other organizations to support transplant nephrology as a potential ACGME fellowship in the hopes of improving that. Shared care models are going to require input with general nephrology, and we need efforts to educate nephrologists, not just on dialysis care, but long-term management issues in kidney transplant recipients, and really changing our practices to limit kidneys that are recovered but not used. And we have many opportunities right now ahead of us, including some challenges here. So in summary and conclusion, the government is very aware of what's going on. We've had major changes in legislation. I think the Trump administration continues to be engaged. We now have a specific CMMI model that is focused on transplantation and access. I think there's a final understanding in many offices across both parties that we need to remove financial barriers and achieve financial neutrality. And ASN has been great in leveraging its network of stakeholders to continue to yield positive impacts. And we're keeping these contacts open through the rocky process of this modernization. And my last slide is just to thank everybody over the last several years that I've worked with in the staff, and in particular our PAC members and our transplant policy members as well.
Thank you, Roz, for that really detailed and complete review. So while we're waiting for questions, if from folks, feel free to add them to the chat. I guess I have 2 questions. So one, given that we have a large general nephrology audience, your thoughts on whether, what an IOTA collaborator role would be and how this new model would affect general nephrology. And the second is, I know there's been this conversation about sharing organ offers and including general nephrology and the patients so they're more aware of what's happening with organ offers. And I wonder what your take is on that and how general nephrologists should view that.
So I might take the second first. So it was not uncommon for me when you go to offer a patient an organ and it sounds less than optimal that they say, but I want to check with my nephrologist. And I appreciate that. I think I appreciate that this is their caregiver for the last X number of years. But I'm also cautious to say, if you turn this down, do you know what your opportunity is for waiting for the next organ? Will you survive? It's more than just match and age of the organ, the KDPI, all these terms we use, infectious risk. So I appreciate the inclusion of those opinions, but oftentimes I really trust, and I don't take organ offers. I usually trust the surgeon, but when there are patients that are uncomfortable, I do meet with them and talk about this may not be optimal, but you're X number of years and the projections are that you may wait, and we don't want you to wait too long and then you're too sick for transplant. Within IOTA, I think every center that I know that I've been able to talk to is engaging differently within programs. Some are doing very intense outreach to their referring centers. As a society, we are talking about better education, particularly focused on long-term care of the transplant recipient, because many of our practices, people have been out more than 10, 15 years. They may not be familiar as much with the literature, with the general care of the little small things that we deal with. And it's some of the small things are the things that patients really care about, like how they look and how they feel, most importantly. So I don't think that I have a great answer. There's not a protocol specifically, but I know that every center has a different take, and it also depends on how aggressive you are advertising. I mean, you have opportunity now you're incentivized to get more recipients, and so maybe going to dialysis units and providing the social worker, who often is the touch point, an opportunity to understand what's out there.
All right, fantastic. Thank you so much. So I guess there's one quick question in the chat from Dr.
Oh, Dr. Mather, what do you think the action should be from an advocacy standpoint? So I think that the professional societies have their own take. I think the ASN has tried to remain open and out of some of the fracas in terms of what we think. Personally, my biggest concerns are transparency and working with HRSA DOT, understanding where the scientific registry is. It's required by law, but as many of you know, we have to answer to the contractor, which is HRSA. Is HRSA even going to exist in the next few months? So I've really depended on Rachel Meyer and David White to keep their ears to the ground, to give us any inclination if they know, particularly with the expected restructuring of HHS. I try not to dwell on it too much, because I don't know what's going to happen. I'm relieved that we finally have a ballot and we're going to be able to move forward. I saw a number of people on the ballot that I trust, so that I think we can try to deal with the two major issues now: out of sequence allocation, as well as this non-utilization of organs. In talking, and another point, Sumit, and I know I'm taking up time, but I didn't think my slides would go that long. I was trying not to talk too fast like a New Yorker. But in terms of understanding organ offers, that was a real part of the Task 5 meeting, that patients really want to hear what was turned down. And it's complicated because it's not like the olden days, and I was around sort of in the olden days, but not completely, where you'd get an offer and you'd bring a couple people in and then you'd say to the person, well, you didn't get it because or you're going to get it because that person's too sick. These offers are coming, and the question is, when do you tell them, well, you were in the scheme, but you were 100, and where is it bountiful for them to understand? And even the field is having trouble understanding the multiple offers that are going on now. So I do think it's much more complicated than saying, oh, well, you're too old, so we let you go. There are things, I think many people are going to be incentivized now with IOTA to clean up their list, so to speak. We shouldn't have 50,000 people being inactive. We should have people transplant ready at all times. If people aren't responding to the phone, that's a signal. And we have many patient advocates now that are working in groups and engaging in terms of being, co-peers to help move people forward.
Well, thank you. I think you hit a lot of key points there.